Thanks for the Angeles Clinic for organizing this and AIM at Melanoma for sponsoring these events, which are all over the world now. And so what I want to talk about is the role of surgery, which has somewhat been neglected. And I wish Dr. Weber was still here because as a friend, we always used to kid about the role of surgery in melanoma. And so it does still have a role. And so I'm going to start from the very beginning. Number one is that everybody here in this room knows that melanoma is an epidemic in the U.S. And as you can see from, I'll make this thing work, but as you can see, these curves or these bars basically show how it's become truly a health problem in the U.S. and the world, likely related to multiple different factors related to sun exposure, changes in our lifestyle, and changes in the environment. And so again, because there's no dermatologist here, I thought I would say something about diagnosis. And so the idea being is that although we can all look up pictures of melanoma on the internet, and now there's even apps for our phone to try to tell us if we have melanoma or not, they're not really very good because the problem is that not every melanoma looks the same, just like everybody in this room looks different. And so although a lot of them will have look like a black piece of tar, the reality is that oftentimes they make the pigment related to the coloring of our skin. And so we see lots of patients who are red hair who have red moles and make red melanomas. So probably the last thing, E, the evolution of skin lesions is probably the most important feature that you can know, because as a person that had melanoma or somebody in your family, number one is if you've had melanoma, you can get a whole new one. And the second is that our family members, although we don't have a way to really test our family members' risk of getting melanoma, they are at increased risk than the general population. So we do need to look at things. And so again, my vote is look for evolution of skin lesions over time is probably the single best way. So I apologize for this. This kind of moves on to after a diagnosis is made. So the concept being is there's lots of debates of what's the best way to diagnose melanoma, but certainly the best way is a biopsy. And so once a diagnosis is made, the next step is surgery. And the margins of excision have gone through an evolution. And so we used to do huge margins of excision, and now the margins have become either 1 or 2 centimeters, which, 2.5 centimeters an inch. So it's almost an inch to a little bit over an inch, or close to an inch. And so these are the general standard margins that are used internationally for melanoma. So as a surgeon, I know that some of my patients are here, and some of them have big excisions, and they wonder, why do I have such a big excision on my back or wherever? But the reality of it is that we actually use a ruler to measure, and so the margins are determined by the surgeon measuring with a ruler. It's not made by the pathologist. But on the left is the thickness of the melanoma, and on the right is the margins of excision. And so whenever you go see somebody for melanoma, it's pretty straightforward. These are the margins of excision, and so if they try to lead you to getting wider margins or more narrow, that's not what's generally been scientifically accepted. And so there's a group of melanomas, this 1.01 to 2 millimeter thick melanoma, where there was never a study to look at the margins of excision. And that's why this 1 to 2 centimeter margin thing is the second line, because, again, it's never been studied. So these are the radial margins from the biopsy site, not from where the melanoma, specifically because the size of the melanoma could be smaller than the biopsy or vice versa, but it's from the edge of the biopsy or the residual pigment on the skin. And then for something called melanoma in situ, which is the very early stage melanoma, we use more narrow margins. One of the questions we are always confronted with is Mohs surgery. And so Mohs to me is peeling an onion from the inside out, going layer by layer. And the problem with this approach is that it depends predominantly on freezing tissue. And when you freeze melanoma cells in the skin, they don't freeze well. So it's very hard for a pathologist to see them when you freeze them. And so determining margins of excision from Mohs is really difficult. And also it goes back to the slide which I showed you probably couldn't see, that margins are determined by a ruler. And so when you peel this onion by layer, you actually lose the ability to measure the distance you are away from it. So number 3 is how the margins are calculated. Is really hard to say. Some of my friends are Mohs surgeons, and most Mohs surgeons in the U.S. won't treat melanoma, but some still do. And certainly melanoma in situ, which is the very early stages of melanoma, there's more controversy because melanoma in situ by definition doesn't spread. So how can you harm somebody if these things never spread? But anyway, that's kind of the take on it. Everybody's talked about the mutations, and so in melanoma, as we talked about, is the BRAF mutations are the most common from the skin. The NRAS are less common, and c-KIT are even less. So we test everybody's melanomas now for these mutations because it may not guide us to determine their prognosis from the beginning, but it may be helpful down the road. So that's an example of a c-KIT mutation from a what's called acrolentiges melanoma on the foot. So our melanoma is all the same. No, they're not the same. But we're looking at, right now, we have 3 mutations we look at in melanoma to help guide us. And so I think one of the other speakers referred to it. So this is a kind of a schematic. This is called gene expression profiling. And what this science has allowed us to do, which has really evolved just as rapidly as immunotherapy and melanoma, is allow us to look at multiple different genes from tumors. And the diagram on the left is called a cluster analysis. And what you can do is our tumors and our cells typically have around 22, 25,000 genes. And it allows you to look at the expression levels of these genes, which then has allowed a new test to come around from this company called Castle Biosciences. And they created this test. They were able to work it down to 31 different genes. And basically what they found, I wish I could make the pointer work, but they found on the right, they decided they could get people into 2 different classes, what they call class 1, which is a favorable group, and the class 2, which is a less favorable. So the idea being is that you could actually discriminate. So this is from the new diagnosis of melanoma. And again, our patients are asking about it. You guys may have seen this, but the concept being is, could you actually determine what's going to happen to somebody based upon the original melanoma from the original skin biopsy? So they're kind of the leaders in this right now. This is evolving really quickly because up until the last few years, the science wouldn't allow us to take a melanoma tumor that was already put in on a glass slide and be able to look at the gene expression, and now we're able to do that. So again, these guys are the first ones to be able to do this, and this test is becoming more popular. So the next question is role of surgery in the lymph nodes. So this question of what exactly the lymph nodes do for your melanoma has been a debate for many, many years. There was kind of the original concept that we would remove your melanoma and then we had to go look in your lymph nodes because that's where it's going to go next. And if it got to lymph nodes and we took your lymph nodes out, that we would prevent it from spreading. And so that's been one hypothesis for many years. And then this other one called the marker hypothesis, the idea being that the lymph nodes are just a marker that your cancer has spread, has been going on. And so this debate has been going on for many, many years, exactly what happens with your melanoma. Does it actually just spread first to lymph nodes and then beyond? Or is, again, the lymph node just a marker? So studies were done back in the 80s and 90s looking at what we called elective node dissection, that is electively just removing all your lymph nodes in the area of where your melanoma would drain. So if you had a melanoma in your arm, we'd take out all your lymph nodes underneath your right armpit or in your groin for your leg. And so the concept was we were going to try to see if we could head off your melanoma from spreading. And what happened was that none of these studies ever demonstrated a survival benefit of just removing all your lymph nodes. So despite that, and I don't have the slide, there was data to suggest that if you have cancer in the lymph nodes and you actually took them out early, you actually did better. So the driving force of the idea of dealing with the lymph nodes was still important, yet just randomly taking out all your lymph nodes was found not to be very effective. So this is where the idea of Sentinel node came about. And so, at UCLA with Morton, et cetera, we developed the concept being is that you could identify this first lymph node using the blue dye, and then it evolved to using blue dye and radioactivity, and then it evolved into breast cancer and some other cancers. But the idea being is you could find the sentinel node, the first node that connected to your tumor, and just take it out and then assess it. And then if you had cancer in the lymph node, then you take out the rest of the lymph nodes. If it was free of cancer, you could then determine that you didn't need to do anything more with the lymph node basin, and the patients in general did really well. And so this was studied in an international trial. It was called the MSLT2, which was completed back in, I think, around 2006, and demonstrated the importance of if you had cancer in the node, you did worse than if you didn't. So a lot of our patients had a sentinel node procedure in order to try to find the people that had worse outcome, because we really had no other clues of how to determine what to do next with our patients with their melanomas after excising the sentinel node, or actually after excising the primary. So that's become the standard. It led us to do complete lymph node sections. And then the question came about is, well, does everybody really need all their lymph nodes out? Because, in fact, a long-term study, it suggests that only a small portion of patients that actually have cancer in the sentinel node will have additional lymph nodes with cancer. So the standard in 2016 is sentinel node. If it has cancer in it, we then take out all the rest. But there's a study going on. It's called MSLT2. It was devised by Morton, and when I was at John Wayne, our group there, and basically if you had a tumor-positive sentinel node, you get randomized to either having all your lymph nodes out or just followed. And so this study has entered all its patients. It's just waiting accrual or just maturation of the study, but it may change everything. And so we're all kind of seeing what's going to happen in the next, say, 3 to 5 years, that if indeed we find that there's no difference between these two groups, that is removal of all of your lymph nodes versus just leaving you alone, that in fact probably this will disappear, and similar like it has in selected breast cancer patients. So the idea being it may be not effective or less beneficial, and we'll stop doing it. Some of the stuff we've done in the lab is we've actually looked at different markers of immunity in the sentinel node, and we found out that if you have particular markers, so this is CTLA4, so it's found to be that if it actually goes, it's upregulated, the patients do worse, and there's another bad, what's called cytokine called IL-10, and so the concept being is that we, in the laboratory, and I saw research that actually this sentinel node, not only telling you if it has cancer in the node or not, but actually its immunologic profile may be important to predicting what happens to you down the road. Again, maybe another step forward in not having to do further surgery on people that have a sentinel node positivity. So nobody has talked about the word interferon today. These guys are medical oncology kind of snooty, but there is something called interferon, and interferon was the first immunotherapy for melanoma. It was approved, I think it was 1996, but the concept being is that this drug was FDA approved in the U.S. for giving for patients who had melanoma in the lymph nodes. The problem is that the reason I showed this diagram is it had potentially a lot of side effects, and it's really limited its use. And then there was a long-acting version called Silotron, and they're both still around, and they're still the standard of care in the U.S. for people that have melanoma in their lymph nodes. The problem being, again, is the side effects. It still has a role, and I think the importance of it is that immunotherapy is really just beginning, because we do know kind of what interferon does, and we kind of know how the side effects are. And here today, all the speakers have talked about anti-CTLA4 and anti-PD-1, and they activate cytotoxic T cells. But then there's another passageway of actually something called NK cells. And nobody has said anything about NK cells, but they're actually really important in immunity. They don't kind of work the same way these guys do, but you'll probably hear more about these in the next few years about their role in stimulating the immune system in melanoma. So because I am a surgeon, I have to talk about surgery for metastatic melanoma, because up until the approval of Yervoy in 2012, I guess, something like that, we did surgery on a lot of patients with metastatic melanoma, and there are certainly a number of people that have had either one surgery or maybe multiple that never got any immunotherapy whatsoever, or never even got any drug therapy and did well. But the problem was, as a surgeon, we never could figure out who those patients were prospectively, and it was very frustrating, and it still is frustrating because we can't really, I can kind of size somebody up, and if they have one lung metastases, we'll take it out, and if they have 6, we won't. And sometimes a person with 6 metastases in their lung might even do better than the person that had 1, but we're not really good at picking it out. And so this was referred to earlier today, this study by Lawrence. The significance of the study, again, is all these little dots, shows the number of mutations that were found in these tumors. And melanoma has lots of mutations. And the reason I show you this chart is because this is kind of what my feeling is like dealing with the patients, is everybody's different. And because melanoma has so many different mutations, we see so many patterns of metastases in here that make it really difficult for us to figure out like how to treat people. And so again, as a surgeon, it's even more frustrating because I can't size somebody up and figure out who to have surgery with, or I can, but it's not really very accurate. And so it becomes really quite frustrating. And so here's an example. This is a PET scan. I know you guys have seen them earlier. So this is, the black is the uptake of the radioactive sugar, which your brain takes, your heart takes up. But this is somebody that you could never operate on because they have multiple tumors throughout their abdomen. So we would skip out on doing surgery on that person. But this is an example of one of my patients. He had a CAT scan, and he had this thing in the small intestine, and it shows up on the PET scan as this black spot, single site. He actually had a lung met too that kind of was up there. And so this was some years ago. So one day we took out his bowel met, his lung met, all on the same day. And now the guy's probably 10 years free of cancer. And again, never got immunotherapy. And today he would certainly have gotten immunotherapy first. He may have even gotten what are the targeted therapies, and maybe never even seen a surgeon. But there's certainly a role for some of these patients. And I could not have predicted at the time that we did a surgery that this would actually work. But again, he was very motivated to have surgery. He was a young guy. He's still pretty young. And he wanted to have surgery. He didn't want to go through, at the time, chemotherapy. And we took him out, and, he's fine. So this has kind of been the standard charts or graphs that we had for many, many years of kind of here's what if you could select patients for surgery for metastatic melanoma, you could see median survival 22 months. Okay. Non-surgical approach is about 9 months. It's probably now been pushed up to probably almost close to this surgery thing right now with the combination of immunotherapy. Probably doesn't exceed it, but these are different groups. These are not selected groups, and these are surgically selected. So we can select patients really well for surgery. Obviously, the patients that are getting other methods are not selected the same way. So the question is, there's still probably 20% of people that probably would benefit from surgery. So we wanted to, this is the kind of things we look at. I'm sorry, half of it's off the screen here. But basically, this is kind of the ways that surgeons in the past would decide if we were going to do surgery for metastatic melanoma. Were they likely to survive? The tumor sites were so-called favorable. They have good performance status. Was it a long time between their original melanoma and their metastases? And again, long is a relative term. We used about 18 months, but that's kind of a relative term. And then what was our role? We were trying to just palliate them, so we were trying to get rid of pain or bleeding, and then also what it was the morbidity. So if we had to take out 5 lung metastases, what's the morbidity of that versus taking out just 1 sub-Q met? So those are kind of things, but these are all kind of all relatives. And so again, kind of in the modern era, this is kind of considered the favorable sites. So lung is a favorable site, skin, lymph nodes, the GI tract, these are all favorable. Brain, liver, considered bad sites, hard to operate on, and thought not to really benefit the patients. So again, kind of in this modern era, this is again a gene expression profiling. So I think the lady from Ames talked about collecting primary melanomas. We've actually been doing it for many years. And so this is one of these cluster analyses. So the green is upregulated genes, and the red is down, and the black is neutral. So all these dots are these are specimens. These are collected primary melanomas, and then we took metastases and we compared them. And what we found out is the METs are very different than the primary melanomas, kind of as you'd expect, and they have particular different gene profiles that may allow these things to spread. And so we did this study. We're just submitted for publication, and what we found out is that if you look at the primaries and the METs, if you take genes that are related to each other, so we're talking about we started with 22,000 genes, and we worked it all the way down to 6, and we found these 6 genes that are related. And I was going to see if Dr. Weber was here because he might know what some of these do. I don't. But there's these genes that really don't have a clear role of what actually they do, but we found that they are more relevant in the Mets than they are the primary tumors. And then we asked the question, okay, if you had these patients and you resected their Mets and they had the profile, what happens to them? And so we looked at these patients and we found 84% survival. So what if you had the profile versus 8%? So what we've determined, at least at initial evaluation, is that the 6-gene profile might be a useful way to pick out who could have surgery for metastatic melanoma versus just guessing as we particularly do it. And so the idea being is this is kind of our scheme of the world now. People with metastases, and again, our research efforts are actually really to try to prevent people from getting here because this is really difficult. Despite everybody's efforts to these new drugs, we really want to prevent this from happening. But nevertheless, kind of the simple way of treatment is, if you have a mutation, you have a BRAF mutation, you may get targeted therapy with a BRAF inhibitor. We talked about some talks earlier today were suggesting if you had a mutation and didn't have a lot of disease, you might get immunotherapy. If you have no mutation, you don't get any of these targeted therapy because you don't fit, so you go right to immunotherapy. It may be that our 6-gene profile, it may be other gene profiles, find our way that we actually do surgery first and maybe do immunotherapy second. We don't know because right now patients kind of go down this route. They get treated. If they have residual disease, we do surgery on them. They sometimes go back on immunotherapy. But the whole idea is to try to get a better way to figure out which patients should be treated in which direction. So anyway, that's kind of where we think surgery fits. This slide has multiple meanings to me and hope there's some meaning to you. Number one is the sun is probably the culprit of all this, or a large part of it. So staying out of the sun or from an early age is probably of benefit. Certainly we can't undo the sun exposure we all had, but educating our family and people around certainly Southern California or the U.S. world about the dangers of sun exposure is important. The second is that I have twins. My twins are 14, and when I first used this slide, this is kind of about the age they were. I think these kids are like 4, so now it's been like 10 years. And so the idea being is, although these kids represent to me my twins, we're all different even though we come from the same family, and so we all at risk for different problems, which is becoming, or health issues, which is becoming more interesting in of itself. We could spend all day talking about it. Is the whole idea now, and maybe some of you have been exposed to, the whole idea of genomic sequencing. So we can actually sequence your whole genome from a blood test. This is something very new. Nobody has really talked about it today in melanoma, but I think it's going to happen. And so it's actually becoming somewhat relevant in some of the other cancers. But the idea being is that maybe we can genetically test ourselves to know if we're going to get melanoma and how to be treated even before we ever get it. So that would certainly be a step forward for to make the world certainly a cancer-free environment. So anyway, I thank you for your time. It's actually really nice to see some of the patients that I'm currently treating, but also some of them that I haven't seen for a long time who have done well and don't come back to me because they don't need surgery, which is really insulting to a surgeon because that's what I like. And so you guys ruined my fun by not coming back. But I'm just kidding because actually it's really nice to know that people do well and have gone on their way and enjoy their life without having to deal with their cancer again. So thank you for your attention.